As a GP over the past 25 years, I've often seen families who are struggling with severe sleep deprivation in the first 6 months of their baby's life. It's awful. And as health professionals, we really want to offer something. And many of us will offer behavioural approaches to babies' sleep in this age group. Now, the term behavioural approach can be very confusing. So let's get our definitions clear. We use the term behavioural approach to refer to a method that aims to increase the period of time for which a baby sleeps at night without disturbing the parents. In the belief that this is in the best interests of both the baby in the short and long term, and in the best interests of the family. So in order to achieve this aim, behavioural approaches will draw on a range of techniques, including delaying responses to the baby's communications or cues, feed, play, sleep cycles, putting the baby down in the cot awake, sleep algorithms, which suggest periods of time for which the baby should be sleeping or should be awake, lists of tired cues, and decreasing the baby's sensory stimulation. These days, some behavioural approaches also recommend responding to the baby, but in a way that doesn't directly respond to the baby's communications or cues. So in fact, behavioural approaches are quite different to cued care as we define cued care. Cued care has as its aim turning down the dial on the baby's stress circuitry as much as is sensibly possible. So cued care aims to set up patterns of direct and sensible response to the baby's communication or cues over time, in the belief that this is in the best interests of both the baby and the family in the short and long term. Behavioural approaches arose in the West in the 1950s and 1960s. That was the time when what we now refer to as first-wave behaviourism really swept the world of psychology and was applied to the care of mothers and babies in the method referred to as scientific mothering. This occurred in the context of very limited knowledge about infant feeding and very limited knowledge about the neurohormones of mother-baby synchrony. In the meantime, first-wave behaviourism has developed into second-wave behaviourisms, which include techniques such as cognitive behavioural therapy, CBT, and has developed into third-wave behaviourisms, including, for instance, mindfulness-based interventions. What's interesting is that in the care of mothers and babies, first-wave behavioural strategies still do tend to dominate. Now, these behavioural approaches have had a very important role to play. They've certainly helped us make sense of the care of mothers and babies. But the very important question for us today is whether behavioural approaches still help, given all that we know now about infant feeding and given all that we know now about the neurohormones of mother-baby synchrony, whether behavioural approaches still help baby sleep in the short and long term and parents' capacity to cope.
So trying to get a sense of what's happening internationally is actually quite difficult. Much of the work that gets done with young infants and the programs that we use are not submitted for any kind of evaluation. We do them because we believe that they're the right things to do. And when you begin to look at all the studies that are published, inevitably it's only the ones that people believe are successful that get through. There are some exceptions, but largely we publish because we want people to recognise what we're doing as having value. So when we begin this process, we need to search all the available sources of these publications using code words that are linked to what we're actually looking for. And then we need to one by one go through the papers that we pick up, finding out whether they're truly relevant or not, whether the age group we're interested in is the age group that's being studied or whether it's just part of it, whether the specific finding that we're looking for has been covered or not, or whether it's the primary issue that's being examined or simply one of many issues that's being explored. The other thing is unexpected consequences or unexpected outcomes of research. So sometimes things are reported not because they were the primary intent of the research, but because they came up. And when we did the analyses, they seemed to be important. So it can be quite a mixed baggage when you're looking at a complex issue like sleep in very small infants. It's not a straightforward picture. Other kinds of research, say for example treatment research, so you're trying to treat heart failure or you're trying to treat epilepsy, these things can be linked fairly directly to the treatment, which is usually a drug, and the outcomes. But with something as complex as the dynamic between mother and baby, evolution of the sleep patterns, the changes in individuals, individual cultural circumstances, all of these things make an enormous difference. So when we look at putting together the evidence, we're actually putting together more than one thing. We're looking at the data that is available. We're looking also at the prisms which we've used, so the interpretation of that data, how we make meaning of it. And when we put them together, we call that evidence. But of course, different investigators will look at the same data with different kinds of lenses. So we will get different interpretations of what we think the evidence might be. When we began this study, we realised fairly quickly that the statistical evidence was only going to be one part of the story, that we'd actually have to put that evidence together in a system of meaning. So we're actually trying to tell a comprehensive story across all of these studies to actually make sense of it for ourselves. And I think that that's what we've been able to do.
So we did the relevant searches of the electronic databases, and through the appropriate process of elimination found 43 studies that have been done worldwide investigating a behavioural approach embedded in a variety of programs to baby sleep in the first 6 months. And when we analysed these studies, we found that we could draw 5 conclusions. So, firstly, the studies show that we can in fact alter the period of time that babies sleep without waking their parents through the use of behavioural approaches to sleep. However, the amount of time that babies sleep is only modestly increased, in fact, by a total of half an hour over a 24-hour period. And some would estimate about 20% less night waking episodes. So we can change the biology of the baby's sleep. We can lengthen the period of time a baby sleeps for without waking the parents and decrease the number of times that a baby wakes at night, but only very modestly. And the vital question is, does this change actually result in improved baby sleep habits down the track? And does this very modest change actually help parents cope? So that brings us to the second conclusion. And the answer to that vital question is, in fact, when we look at these studies worldwide, no. The studies show that there is no link between the use of behavioural approaches to a baby's sleep in the first 6 months of life and improved sleep habits down the track in later childhood. The studies also show that whilst postnatal depression is certainly linked with unsettled baby behaviour, postnatal depression actually doesn't relate to the number of times that a woman is woken in the night by her baby, but by her sleep efficiency. That is, by how long it takes her to get back to sleep once she's been woken in the night. It's also very important to note that any intervention, any consultation or encounter with a kind and caring health professional certainly improves maternal mood as we assess it on maternal mood scores. But that's regardless of the content of that encounter. So whilst there are studies that link behavioural approaches in the first 6 months to improved maternal mood scores, we simply can't say that this improvement in maternal mood directly relates to the behavioural component of that intervention, because all sorts of other things could explain it. Also, it's really important to know, when we're thinking about these studies, that a maternal mood score actually doesn't necessarily indicate a diagnosis of postnatal depression. So if the maternal mood scores are on the high side, they're nevertheless only one factor that a GP, for instance, would take into account when making a diagnosis of postnatal depression. And you'll find that very often researchers are taking a particular maternal mood score, say from the Edinburgh Postnatal Depression Scale, and stating in their interpretation of these scores that their intervention actually decreases rates of postnatal depression, and that simply isn't the case. So this brings us to the third conclusion that we've drawn from our analysis of all the studies worldwide, and that is that the studies overlook the link between feeding problems and sleep in babies in the first 6 months of life. So, have you ever noticed, for instance, that your baby falls asleep at the end of feeds? Or that your baby wakes with hunger? So, of course, parents commonly notice this link, and it's because the neurohormones of feeds profoundly interact with the neurohormones of sleep, particularly in the first months, but still relevant at 6 months of age. Excessive night waking in the very young baby very often points to unidentified and unmanaged feeding problems. But unfortunately, this isn't taken into account when interpreting the evidence concerning behavioural approaches and baby sleep. In fact, behavioural approaches aim to disrupt the neurohormonal link between feeds and sleep with, say, the feed-play-sleep cycles, and also will often advocate spacing out feeds. So these approaches tacitly acknowledge that powerful link between feeds and sleeps. But when the researchers are interpreting their data, they ignore this link in their interpretations. So our fourth finding is that the studies concerning behavioural approaches into infant sleep in the first 6 months also tend to ignore the profound neurodevelopmental differences, the profound differences in needs between babies who are under 6 months of age and older babies. And we find that very often data that's been performed either on the older babies or on a group of babies with a very wide age range from say 0 to 12 months, the results from these studies are then interpreted as applying to the younger babies who have such different needs. And then the fifth conclusion that we draw from our analysis is that in fact behavioural approaches to baby sleep in the first 6 months of life are associated with unexpected outcomes. We've already talked about how an intervention or an approach being inserted into the complex system of the mother and baby risks unintended outcomes. And the application of behavioural approaches results in premature cessation of breastfeeding, so early weaning, in increased levels of baby crying, and in increased levels of parental anxiety. And of course, we know that anxiety itself interferes with sleep efficiency, interferes with parents' capacity to get back to sleep when they've been woken at night. At Possums, we take an approach that acknowledges the interrelationship between the 5 domains of baby's health, mother's health, feeds, sensation and sleep. So the way sleep interacts with all these other factors in a family's life. We support cued care, understanding that cued care only makes sense if we're helping parents sort out underlying problems that are so often unidentified. And in our preliminary study of 20 mothers whose babies had cry, fuss issues, those parents found that the babies' crying and fussing substantially decreased after they saw a Possums health professional. Also, in this preliminary study, we were able to demonstrate improved maternal mental health scores. But as we've discussed, we'd expect this result from any kind and caring intervention simply due to reassurance and support. So the way of the future concerning healthy parent-baby sleep is to offer cued care in the context of proper help, sorting out any problems that may be underlying the baby's disrupted sleep, and in the context of support with techniques that we know improve sleep efficiency for parents and bring peace of mind. So this is what we do at Possums. It's integrated, interdisciplinary and holistic, and we invite you to take a look.